Hello, future PTAs. I hope you guys are doing well. All right. I'm gonna start. Sorry, I was exiting out of some things. Today we're going to talk about proprioceptive neuromuscular facilitation, PNF for short. So here is kind of some of the basic principles that come into play. A lot of this I'll just kind of mention, go through like what the patterns are, what the techniques are, and then we'll do a lot of our, how do you position your body? Where do you place your hands? When do you provide a stretch, and when do you provide resistance, and how fast do you move or how slowly, and do you do rhythmic, and not do you have them contract or relax? All that is really key in every PNF technique, but a lot of those specifics we'll go over in lab. So today is a general overview of what PNF is, what the patterns are, and how to use it. So PNF has some principles about your hand placement, your body position, your stretch, how much resistance, irradiation, which is like spreading muscle activation from stronger muscles to weaker muscles, facilitation, of course, that's trying to activate a muscle, movement timing, movement patterns, the cues that you give, the input that you give, verbally, visually, tactile, and then how you use each pattern, whether it's to facilitate or inhibit tone, facilitate muscle contraction, inhibit tone, to assist with stability or to decrease spasticity. I mean, there's different specific techniques for each PNF technique. There's different technique is the word I'm going to use over and over that you use based on your goal. Okay. You can use it with a lot of different types of patients and a variety of patient populations, but knowing those things and how to handle them is key. So the first thing we're going to discuss is the patterns, PNF patterns. So there are upper extremity patterns and lower extremity. D1 is the name of the first upper extremity pattern. D1 flexion, you bring your shoulder into flexion, adduction, and external rotation, almost as if you are reaching to grab your earring or to throw a scarf over your shoulder, and that's going towards flexion. So it's named based on what the proximal joint is doing. So it's going towards flexion versus D1 extension. Now the shoulder is going towards extension, and you are also extending the elbow, abducting and internally rotating the shoulder. You actually kind of like flick your wrist behind you. So D1 flexion goes towards the ear to grab your earring and then throw it behind you. One way I remember the difference between D1 and 2 as far as the upper extremity is that you take off your earring before you grab your sword to fight. So I know we don't usually sword fight, but if you were, I bet you would have to take off your earring first. So take off the earring is D1, flexion and extension. So do it with me so that you get an idea, because they're hard to remember the exact movements unless you're doing them. So even if you're taking the boards exam, you can easily grab and say, okay, what is my shoulder doing? It's flexed, it's adducted, it's externally rotated, and be able to answer a question if you can do the movement itself. With D2 flexion and extension of the upper extremity. So with D2 flexion, the shoulder is flexed, abducted, and externally rotated. So flexed, abducted, externally rotated, like that. Okay. So that is the D2 flexion. And the extension is like you're putting a sword in your pocket. And something we do more often, we might be a little more familiar with, is putting on a seatbelt. You grab the buckle behind you and then you buckle it in at your waist. Okay. So that is D2. Putting on your seatbelt is D2. So you put your scarf on first before you put your seatbelt on. If it's cold outside. All right. So D2 flexion is shoulder flexion, abduction, and external rotation. And you grab the seatbelt and then you go to towards extension, adduction, and internal rotation, as if you're putting the the sword back in its sheath, or you're buckling your seatbelt. That is D2. So D1, do it with me again. Grab the earring and throw it behind you. That's D1 for the upper extremity. D2, grab your seatbelt and buckle it in. That's D2, flexion and extension. Again, either it's called flexion or if it's called extension, is what movement your shoulder joint is moving towards, your proximal joint. So flexion for D1 and extension, and for D2, it's flexion and extension. This is just a cute little meme about if you're asked to join a dance circle, but all you know is PT moves. So he's doing D2, and it says it's got you looking like John Travolta. So you might want to remember this next time you're in a dance circle. All right, there are also scapular patterns. So there's anterior elevation, so going to the front and up and forward, which is D1 flexion is anterior elevation. D1 extension is posterior depression. So D1 is kind of the one I typically have people do more often. Like if I'm doing like reverse shoulder rolls, I'm doing D1 extension, going down and back. D2 is posterior elevation, which is even harder for me to do. Like you're squeezing your shoulder blades together in the back, like maybe somebody tickled your neck and you're like, eek. And D2 extension is anterior depression, which is also hard to do, to go down and forward. I don't know that I do that much, so I don't have a good example of when we do that, but I use D1 scapular pattern a little bit more than D2, where you go up towards your ears and back down, and I focus on people usually going down and back and kind of pinching their shoulder blades together in the back. For your lower extremity patterns, that D1 PNF pattern, D1 flexion, your hip is flexed, adducted, and externally rotated, almost like you're bringing your foot across to put on a shoe. I'm going to stand up and see if it will still record me or if I fade into the background. So also kind of like that Peter Pan leg. So you go flex, adduct, and then externally rotated. That is D1 flexion, and then the extension goes to extend, abduct, and externally rotate. I'm fading into the background. Okay, so D1 flexion, you bring your leg up and in like you're trying to cross your leg to put a shoe on, like that bottom picture. And then the D1 extension for the leg is like the skateboarder in that picture, where your leg is straight behind you, abducted, so out to the side, and internally rotated, like you're pushing to push the skateboard forward, his back leg. Okay. So I would pause it and stand up and do those yourself. I actually may be able to take my background off and show you better. So let's do it together. D1 for lower extremity, D1 flexion and extension. Flexion and extension. All right. Now we are going to D2, which I had already changed it at some point. Sorry about that. So D2 flexion for the leg goes from hip flexion, abduction, and internal rotation, like the fire hydrant. So hip flexion, abduction, internal rotation. Bad day to wear a skirt. It's a skirt. To hip extension, adduction, and external rotation. So behind you. So let's do it together. We go from hip flexion, abduction, and internal rotation, like you're kind of trying to hike your leg up to pee, to hip extension, adduction, and external rotation. So like kicking behind to peeing. They say the soccer kick, but I don't see a whole lot of adduction with a soccer kick, so that part of it, loses me just a tiny bit. I also don't play soccer, so maybe it is a good soccer kick. Maybe that does help you. All right. We are back with a background on. So D1 with the arm, D1 flexion, D1 extension, D2 flexion, D2 extension. Now with the leg, I'm going to stop this with the background because it's going to get annoying. Maybe I'm already annoying. All right, with the leg, D1 flexion, Peter Pan leg, and extension, D2 flexion, and extension. All right, D1 flexion, D1 extension, D2 flexion, and extension. All right, so I would certainly be practicing that, and I may do it once more before we end this presentation, because if you get anything out of today, that would be the main take-home message, is knowing the difference between D1 and D2 flexion and extension for the arms and for the legs. Of course, the scapular patterns are great, and we're about to go over some pelvic patterns, but the ones you'll use the most in the clinic, likely, unless you're maybe a pelvic floor PT or something very specific, and the ones you probably see most on your boards are the D1 and 2 flexion and extension for the arms and the legs. All right, pelvic patterns. I'm actually sitting on a ball now doing some pelvic patterns. And so anterior elevation is forward and up, just like with the shoulders. Posterior depression is down and back, just like with the scapular patterns. D2 flexion is posterior elevation, once again, up and back. And D2 extension is anterior depression, forward and down. Okay, so those are a little bit harder to do. I do find that unless like somebody's laying on the table and you're moving their pelvis for them, that one of the best positions for somebody to kind of work on some of these is sitting on a ball and kind of moving their pelvis like forward and backwards, side to side. Some of that can help them work on like dissociation and being able to do one thing with one set of muscles versus the other. So that's why I had that picture there. I feel like that's a good position for working on these pelvic patterns. All right, so these are the different PNF techniques that we're going to go through. Score builders actually also list joint distraction and repeated contraction as PNF techniques. We won't go over those today because they're not in your book. But just know that you might want to just look over those to be a little bit familiar with those in case that wording is used on your test. But the rest of these are also in score builders and are important to know the difference between. So I'm going to go over just some like basics, like highlights for each type. And then in lab, we'll go over how to do them. So rhythmic initiation. So the movement progresses from passive to active assistive to slightly resisted motion. So you're going through the pattern, you're first moving them through it yourself, then you have them help you, and then you say pull against me. So some of the cues are let me move you, like relax, let me move you, help me move you, so move with me, and then move against the resistance or move against me. I'll try and stop you, you try and push through. Cues are really important, so I'll give you a cue or two on some of these to help you understand how to use them. You want to be slow and rhythmic with this pattern, which is good that it's called rhythmic initiation. It's good, easy to remember, slow and rhythmic. And it's used to decrease tone and promote full range of motion. So if somebody who has a lot of tone and it's limiting the range of motion, then rhythmic initiation is a good pattern or a good technique to use. With rhythmic rotation, this is also to reduce tone, and it's typically more so with the lower trunk rotation and hook lying. You could do possibly maybe shoulder rotation. So you could have a patient laying down and you could kind of move them through it yourself, or you could have them do it back and forth for rhythmic rotation. It's usually in preparation for other movements. All right, hold, relax, active movement. So first you put the patient's limb in a shortened position and they're asked to isometrically contract to hold it there. Then the patient's limb is moved to a lengthened position and they're asked to move it to the shortened position. So you shorten it and you say hold. I'm just going to do it like my biceps. Shorten it and say hold, and then you lengthen it and you say move it back, and they move it back to that shortened position. It's trying to contract a muscle that they have weakness in. Okay, so you move it to a shortened position where they have a contraction of that muscle, and then you say hold and you let go of it, and they try and hold it in that position. And then you say relax, you move it to a lengthened position and say pull back to that position. You don't have to say those. I'm not giving you the best cues right now, but you can say pull back to that position, or bend your elbow back, or what, just depending on what joint you're working on, and then they bend it back to that position. You can use a little bit of light resistance to help facilitate the movement if necessary, but your goal here is to facilitate a muscle contraction. With hold relax, you first move the extremity to the point of limitation, so you get all the way to their end range. Then you instruct them to maximally contract the antagonist muscle while you resist them. So you get all the way to the end range, and then you say pull against me as hard as you can, or match me is a better cue that we typically use. Match me, and then you count 1, 2, 3, all the way 5 to 10 seconds. I like to personally keep it consistent. Whatever number I choose, I kind of use that same number. And then you say relax and you repeat another cycle. Typically, if I have them hold, personally, if I have them hold for 5 seconds, I then have them relax for 5 seconds in between. And you keep doing that until they don't gain any more motion. So the idea is that when they relax, you're able, so maybe I'm just using this because it's the only limb you can see really very well. So maybe they're only able to get this far, and then you say push against me, and they push against you, and then you say relax, and you try and push them a little bit further. Match me, you push against them, you count to 5, then you say relax, and you try and pull them a little further. And when you're at a point where you're like, okay, they're just not going any further, then that's when you stop those cycles. It's used to help increase the range of motion in patients who have restrictions that are typically related to pain. So if they have that empty infield that you feel like there's more motion to be had, they have more range, you just can't get there because they're tightening up against you, there's a lot of muscle guarding or pain that's stopping them, then this is a really good technique to use. It does say maximally contract. In some instances, I personally don't feel like if they're in a lot of pain that they're able to do a maximal contraction. So that might be another reason to use that match me word or cue that the book recommends, so that they're able to just do it without, stirring up more pain. All right, our contract relax technique. So stretch the extremity through the available range and then have the patient contract the antagonist muscle to increase their range. Again, you hold that contraction, have them hold it 5 to 10 seconds, and then tell them to relax, and you repeat until they're not getting any more range of motion gains. So this is a very similar technique. The difference is it's used for patients with minimal pain, and you're going all the way to their in range. That's where you're kind of starting before you have them do their first contraction. Oftentimes you can see significant changes in muscle tension with this technique, that they get significantly more range after, but it is typically used in patients who are not limited by pain. All right, alternating isometric. So you instruct the patient to alternate the isometric contraction. So you would say like push up, push down, push up, push down. So it's kind of a quick alternating movement where they are switching from one side of the joint, contracting on one side to contracting on the other side of the joint. And it is used to increase endurance or strength. It can be used in developmental posture and postural muscles. Sometimes what I'll do is I'll have somebody sit still and I'll say, stay still while I push you, or something like that. That's not push, maybe not stay still while I push on different areas. I mean, I might say push you, but it doesn't sound great. And I will like do little perturbations where I push them in different ranges and I say, stay as still as possible. That might be a better cue. Stay as still as possible. And then I do little light pushes all around to help them with those postural muscles to be able to maintain that upright position as they're strengthening. With rhythmic stabilization, you have them contract muscles surrounding the target joint at the same time and progressively add resistance. This is for stability and balance, to decrease pain with movement and increase the range of motion and strength. So you're having them kind of contract muscles all around to help with the joint stability. With slow reversals, they do a concentric contraction of muscles in an agonist pattern, facilitated through manual contacts and verbal cues. You're trying to minimize fatigue by rhythmically alternating between the agonist and antagonist muscles. So you just kind of slowly hold, now relax, hold, and you're just kind of going back and forth between the two muscle groups slowly to concentrically contract each muscle group. Slow reversal hold, basically the same thing with a little longer hold. Resisted isometric contraction at the end range in each direction. So you kind of put on the end range, say hold, and then go to the opposite end range. It is also used for stability, and you can use it on extremity or on the trunk, or you could do it with functional movements. As they're doing functional movements, have them hold the positions with this technique. All right, agonistic reversals. So you instruct the patient to perform a concentric contraction against your resistance, and then followed by alternating concentric and eccentric contractions against resistance. So you are switching, again, your hand placement as needed as you alternate concentric and eccentric contractions. It needs to be slow and sequential, and you're trying to help them attain maximum muscle control. It helps them facilitate functional movements throughout the pattern. And you're targeting the agonist muscle groups. That's why it's called agonistic reversals. Here's our final one for today. It's resisted progression. So this mainly focuses on locomotion, on movements, and you can apply it during crawling, during creeping, where you are trying to promote a movement and you're adding resistance throughout certain directions of that movement to help promote function and stability of that movement. All right, so we're going to go through the developmental sequence from supine to rolling to prone to quadruped, kneeling, sitting, scooting, sit to stand, standing, and then pre-gait. And we're just going to kind of quickly mention the different movements in each category. So with supine progression, when you're teaching somebody bed mobility, you first work on hook lying, then bridging, and then scooting, because they kind of have to bridge up to scoot. Of course, I wouldn't start out with bridging with weights, it's just a picture I found, but that's your supine progression. For rolling, you can use some antagonist patterns of the right extremity to help somebody roll from the left side to supine. So whichever direction you're rolling towards, you can do some patterns to help prepare them for that roll and then assist them with rolling. Rhythmic initiation is a good PNF pattern to use to assist somebody with rolling. With prone lying and prone on elbows, typically they'll start out with kind of a wide base and then kind of get more narrow and more pushed up onto their elbows before they eventually go to extended arms. Rhythmic initiation is another technique you can use in this position with manual cues, with graded assistance. And teaching the patient to transition from prone to prone on elbows. And this is really a key position in people who've had spinal cord injuries for functional mobility and for bed mobility and independent turning. So it's a great position to know how to walk a patient through. Quadruped, one of the first postures in the developmental sequence where the center of gravity is significantly further from the supporting surface. The others, your center of gravity is almost directly on the supporting surface. Rhythmic stabilization is one thing you could use in this position where you can help with stabilizing the trunk, and then you can use a slow reversal technique on one of the extremities to help with core stability and with freeing a limb for movement. It could even be used in young children to promote crawling or creeping types of behaviors. Kneeling first, you will do typically the tall kneeling, really short kneeling, and then tall kneeling. It's one of the first positions that allows for axial loading or weight bearing through the hips and the spine. And then half kneeling, which is a harder and a progression of kneeling. But it's great because it's the kind of the preparation stage for standing up, for going from sit to stand. So half kneeling is great for core control and for progressing from the floor to standing or from one position to another. For sitting, this is our primary position we use for functional task. Rhythmic initiation and hold, relax, active movement are some of the techniques that are often used in sitting. As you see, you can use it, with one extremity and following that extremity. It's always nice to instruct the patient to follow it with their head so that they're getting a lot of input and awareness of where their body is in space. And you can help teach the patient to assume upright sitting while giving different resistance around the trunk to help that core stability. All right, with scooting, the main key to successful scooting is the weight shift. So, like in the picture, if you're trying to scoot in the wheelchair, you want to lean to the opposite side before you scoot. To take the weight off of the side you need to scoot before you scoot that side. So he's leaning to the right to scoot the left up. So if you're wanting to scoot one leg up, you lean the other way and then scoot, and then you lean back and then scoot. If you are wanting to scoot a patient's hips backwards, then have them lean forward and then help push them backwards to take the weight off their hips before they are scooted. Rhythmic initiation and hold, relax are some of the useful techniques for scooting. Sit to stand, you must first lean forward and put the center of gravity over your base of support before you push up and lift your body. That is one of the biggest things that I have to teach people when they're like learning to stand again or they've had some type of injury. It's something that people typically do naturally when they learn to stand up from sitting without ever putting any thought into, I lean forward before I stand up. Until, you might want to try it at home, try and stand up without leaning forward. Just stand straight up, and it is super hard. It takes a lot of strength. But if you lean forward and take the weight off your hips, you got it's a lot easier to stand up and use those leg muscles. So hand placements are also essential. Some people may push off of their legs or pushing off the arms of the chairs. Hand placement of the therapist is essential in helping and guiding the patient for these types of movements. With standing, there's varying muscle contacts, can't read, that help with the amount of resistance and how to challenge the patient when they're standing and changing the lever arm. Of course, I like this picture because he's doing a PNF pattern, but with standing, but with a TheraBand for resistance. And I see that as a patient, advances and progresses, that's a really good use of PNF patterns for like functional strengthening. If they're not maybe to that level where they can use TheraBand or they're not able to stand and support themselves on their own, then maybe you could help them in some instances and resist them in others. So like maybe they need help progressing the right leg, but then you can kind of resist the movement of the left leg, just, kind of depending on what your target muscle groups are and what you're trying to work on. So you can make it, various functional movements in standing that you add different resistance and hand placements depending on your goals. It helps you develop stability, and you can use alternating isometrics, rhythmic stabilization, anything like that in this position. Pre-gait, controlled mobility activities are targeted at acquiring the skills needed to walk. Some of the techniques we can use for walking are slow reversal hold, agonist reversals. They all help reinforce and facilitate types of muscle contractions and movement strategies that are crucial for movement for walking. So again, we're going to go over what some of this looks like in lab. But that is kind of a basic knowledge of PNF. So I hope to see you in the next lecture.